I'd like to now introduce my colleague, Dr. Mark Richardson, who works with me at the University of Pittsburgh Department of Neurological Surgery, where he is the director of Epilepsy and Movement Disorder Program, and also directs the Brain Modulation Laboratory. In other words, Mark's practice is primarily restricted to patients with functional disorders, movement disorders, and problems like epilepsy. Mark has been funded through the National Institutes of Health, and he has taken a good program at the University of Pittsburgh into an exceptional program. I think it's safe to say that everyone at our institution is really watching what he's doing, and I hope that you'll enjoy his talk today. Thank you very much.
Okay, Dr. Skula, thank you very much for inviting me. You've put together a great program. I really commend you for your commitment to patients, really, and your interaction with this organization. It's fantastic. I've learned a lot today, and hopefully some of you will learn some new things about DBS if you don't already know about it. Just raise your hand if you think you know what DBS is. Just raise your hand to get a sense. Okay, so most people have heard about this. But I've kept this kind of fairly simple, but get out your index cards and you can hit me with the advanced questions or basic questions at the end. But there's a lot of misunderstanding about what deep brain stimulation is, and hopefully we can clarify some of those things today. Let's see if this is going to work. I'll just click this. There we go. Okay, so this is what I'm going to talk about. What is DBS? Does DBS improve facial dystonias? How does it work? I've got one slide on this. Dr. Evinger just gave us some background into how it might work, so we'll talk about that briefly. What happens during DBS surgery? So I think this is something that people are very curious about. So we'll spend some time talking about the techniques of DBS and what it's like to undergo surgery. And then lastly, we'll talk about who is a candidate for DBS. I think this is probably a question that a lot of people have that consider this option for any movement disorder. All right, here's a video I stole from the Medtronic website. They're the company that currently has a monopoly on FDA-approved deep brain stimulation. So they kind of go backwards in the video because they start with showing you the battery pack in the chest. But this is actually the deep brain simulator. This is the computer that delivers electrical current through a connector wire that then is anchored to a locking cap, basically, in the skull. And we usually do one on each side, but sometimes we would only do one side. And there's a thin wire. It's about 1.3 millimeters wide. That's inserted deep into the brain. That's why it's called deep brain stimulation. And I have gotten in the habit of using this cliche. It is kind of a pacemaker for the brain. And that's a generic term that's been applied to DBS. But as we have gotten more insight into how it might work, it does seem that it paces the brain in the sense that it inhibits abnormal brain activity from happening. Okay, this is what the end of the electrodes, this is the business end that's in the brain, and there are three different types of electrodes that are used. The ones that I use for dystonia are these shorter, are the ones that are spaced closely together. Others use these, and this is approved for another indication where the target is much larger. The device works the same way that it did when this was developed. Okay, so the device works the same way that it did when it was developed about 15 years ago, and it's kind of a really dumb way to stimulate, in that there are three components of the electrical stimulation that can be controlled. One is the duration of each individual pulse. The other is how frequently these occur, so the rate of pulse that's delivered. And lastly, you can control the strength of each pulse. So through having done this first in animal models and then in people for now more than 15 years, we have a good sense of what these parameters are that work for movement disorders, and they tend to be fairly similar between different disease states. Okay, so what are the indications for deep brain stimulation? So Europe has always been ahead of the United States in terms of approving this therapy. So the first Medtronic system, though, was implanted in 1987. So that's actually quite some time ago. People think, you see things in the paper, well, here's a new therapy, you look at deep brain stimulation, experimental, et cetera. This is not an experimental therapy. In terms of its optimization, we do have some work to do. But in the United States, it was first approved for essential tremor in 1997, for Parkinson's disease in 2002, and for dystonia in, and I always forget this number, 2003. It was approved for dystonia, I will just add, under humanitarian device exemption. And that essentially means the FDA has approved this in the absence of larger randomized control studies, although subsequently there were two in Europe that did show the efficacy of deep brain stimulation for dystonia. And there is also now an approval for deep brain stimulation for obsessive compulsive disorder, also under humanitarian device exemption. Okay, so let's just jump to this question. Does deep brain stimulation improve facial dystonia? And let's just begin by starting with generalized dystonia, which is really the first type of dystonia in which DBS was widely applied. And so it's deep brain stimulation is indicated for either unilateral or bilateral stimulation as added management for chronic and intractable, which means medically refractory, primary dystonia. So even though we can and have used deep brain stimulation for secondary dystonias related to various brain injuries, it's actually only FDA approved for primary dystonia. But facial dystonias are not always, as we learned from Dr. Jankovic, but often primary dystonias. Okay, so a generalized dystonia is a dystonia that affects most of the body. Segmental dystonia is, by definition, two adjacent body parts. So this is what we learned is incorrectly referred to as Mage syndrome. Oromandibular dystonia, for instance, with blepharospasm, or oromandibular dystonia with cervical dystonia. Hemidystonia is a dystonia that can infect both the upper and lower extremities on the same side of the body. And then cervical dystonia is one that you all know about as well. This can be a component of craniocervical dystonias. Okay. So let's talk about DBS for generalized and segmental dystonia. So the typical target is globus pallidus. This is part of the basal ganglia, which is a communication center in the brain that is important in signaling how movement is controlled. The published clinical results so far for generalized and segmental dystonia are now in over 300 patients, if you look at the worldwide literature. The approximate improvement in symptoms, if you look across these studies, is anywhere from 40 to 70%. There is some class 1 data, so that's 2 studies, European trials that have done randomized control studies of DBS for generalized dystonia. There are similar results in cervical and craniocervical dystonia, but with much smaller patient series. So there's reason to believe that DBS can be just as effective in appropriately selected patients, but the numbers are much smaller. To my knowledge, there are no published studies on DBS for standalone blepharospasm in the absence of oromandibular dystonia or cervical dystonia. And our other experts can correct me if I'm wrong there, but I believe that's still true. And I'll tell you about a couple, and I did throw in May's syndrome there, although I agree that this can be a little bit of a confusing term. So I trained at University of California, San Francisco during a time where they were working on this study, which was looking at globuspallidus stimulation in patients with craniocervical dystonia. So these patients had a combination of blepharospasm, jaw, tongue dystonia, and cervical dystonia. And this was actually a trial that consisted of only 6 patients, but it's still one of the better small trials that's been done. And they used 2 rating scales, Toronto Western rating scale with 54% improvement, and the Brooke Van Marsden scale, another classic scale, with a little bit higher improvement there of, I think, 73% in those patients, and that was at 6 months. However, many of these patients developed a slowness of movement called bradykinesia and body parts that were not previously affected. So, for instance, some of the patients who had bad facial dystonia had a problem in speed of movement in their hand, okay, on the same side, problem with fine motor skills. In some ways, that can be dealt with by changing the simulation parameters. There can be different settings on the DBS, for instance, that can be used in different situations. But this is an unwanted side effect, and so the group at UCSF wanted to see if possibly another brain target might be as beneficial without creating this unwanted side effect. So a few years ago, they published this paper and used another target in the basal ganglia called the subthalamic nucleus. And by the way, these are the 2 targets that are used in the treatment of Parkinson's disease. And this was a little bit larger study, 9 patients, not a whopping number, but also a little bit longer follow-up of 12 months. And on the Toronto Western scale, an improvement of 63% in terms of symptomology, of symptom reduction. Now, all of these patients also developed an unwanted side effect, which is stimulation-induced dyskinesia. So this can happen from an overstimulation of the subthalamic nucleus, and in fact, that's what these patients have. Because the take-home message, I think, for deep brain stimulation in general, it's something that's very important that I talk to patients about, to make sure they understand that this is a treatment that can be effective in treating symptoms, but it does not treat the disease. So the problem in dystonia is unlikely to be in the subthalamic nucleus, although signaling through the subthalamic nucleus could be involved. But stimulation there is a way to disrupt abnormal signaling that happens within brain circuits that lead to unwanted involuntary movements. Just check the time. I did want to show you, and I will point to both screens, a few images there. 3 patients as you go down that show you where these brain regions are. So this is a patient. Each column is a brain, and the globus pallidus is visualized here, steep in the brain. The subthalamic nucleus is here. So this is a blow up of the larger, what we call axial slice of the brain. So that's if you take a slice like this and then look up the brain. So I can point out over here, globus pallidus is here, the subthalamic nucleus is here. Okay, so these are the deep brain structures that can be targeted for dystonia. Okay, here's an example. So just this past week, I operated on 2 patients that I thought would be of interest to you. So I have their videos, one now and then one at the end. So we'll just, let me turn this up and make sure that the audio is loud enough. I've got a pre-op and then post-op on this patient. see if this will play. Oh. Hold on one second.
He'll say, I heard them speak on the radio today.
I heard them speak on the radio today.
No ifs, ands, or buts.
No ifs, no ifs, they
Don't take your chin or hand away from your chin. Now I'll say, I heard them speak on the radio today.
I heard them speak on the radio today.
No ifs, ands, or buts.
No ifs, and buts.
Okay.
Well, I had the surgery October 4th, 2012. I feel pretty good. The head doesn't move as bad. Speech has improved slightly. Overall, I'm very happy with the whole situation.
Okay, so I think this case, oh, by the way, that video is also, it's not quite fair. It's like the kind of weight loss thing where they take a very bad picture of the person and then they, give them a makeover and take a better picture. And I honestly, I think the ratio of the video was a little off, so some of his dystonia looked worse. But nonetheless, I think this highlights some good points about DBS. So this isn't a case that I would call a home run, like some of our other movement disorder cases we might do for essential tremor or Parkinson's disease. But this has, without a doubt, led to significant improvement in Andy's quality of life. He did give me permission to use his name and the video. He came back for his first battery change 22 months after surgery, so that's not quite 2 years. In patients that undergo DBS for dystonia, the settings are often high that are required for symptom control. So one does have to come back to have the battery replaced, usually sooner than happens with other indications for DBS. You can see that, so he did not have Blepharospasm as a component of his disease, but he had gone through multiple years of having Botox injections in his neck. And you can tell that he had a very bad jaw and tongue tremor that significantly affected his speech. So when he came back for battery change, he gave a fairly classic story, which is that it can take easily up to a year before patients will say, okay, you know what, I now know that I'm very happy that I had the surgery, but I wasn't sure up until now. And there really is a delayed and cumulative effect. Probably has to do with how the deep brain stimulation is changing the plasticity of the circuits in the brain, and it can take some time to have a good effect. You saw his head was midline, his speech was much improved, but by no means was he cured. So how does this work? I have one slide because we're still over the past several years are just now starting to understand how deep brain stimulation works, and it probably does so by disrupting abnormal communication between different brain regions. So Dr. Evinger talked about this and how in different disease states the brain is coaxed into, and neurons in different parts of the brain are coaxed into firing the same way. So there's abnormal synchrony both within different parts of the brain and then between parts of the brain. And we know that the brain communicates by interacting with these different oscillations in different bandwidths. Some are slow, some are fast, and that's how information is processed. So deep brain stimulation, and we don't exactly understand how, can disrupt the abnormal oscillatory activity while still letting the normal functions proceed, with some exceptions like the unwanted side effects I told you about from stimulating in some dystonia patients. And there are different loops through the brain that we think are segregated, related to different brain functions, and that's how you can have a problem in one brain circuit and still be normal with the results to the other brain circuit. So you all know people with facial dystonias are normal people with normal cognition, and a lot of people that at C. People with facial dystonias don't understand that, but we do, and one reason that is because these circuits in the brain are segregated. Okay, what happens during DBS surgery? There are two approaches now. So the first is the traditional frame-based awake surgery. So this is one that you may have seen videos online or seen a picture of a patient in a stereotactic frame. Some people call that a halo. It's not a halo, but it's okay to think about it that way. It is temporarily bolted to the head during surgery. And there is now a new type of surgery where we don't have to record from the brain, which is why we otherwise need patients to be awake. The reason that we do normally record is so that we can verify when we're in the right place in the brain. The other way to verify that is by looking at an MRI in real time. So we can now do this with an interventional MRI method. Here's an image that just shows a typical setup in the operating room. So here's a lady undergoing DBS. She has a stereotactic frame on. And this is the rest of the surgical team. We have a neurophysiologist, I have an assistant, and then I have another physician assistant who helps with programming and testing in the operating room. Let me play this for you. So again, the reason that we have patients awake is so that we can listen to the sounds of the brain. So this is the activity of a single neuron that's isolated, and we can record these much better with patients awake with their eyes open than we can, for instance, if they're asleep and under general anesthesia. That's a longer cell than I thought. Here's another cell. So we advance the recording electrode first through the brain, and different areas of the brain have different signatures of neural activity. So you're listening to the electrical amplification of neural activity. Okay, so I think you get the idea there. So that's the brain mapping part of the procedure. So that's how we determine that we're in the right place. And then when we think we've got it with the electrode recording, then we put in the stimulating electrode, which is the one that's going to stay there permanently, and we turn it on to make sure that there aren't any bad side effects at too low a threshold. Okay, I think this is a pretty quick video that will... also give you a little more of an idea of what happens. So this is the setup for the recording electrode. This is fixed to the stereotactic frame that is attached to the patient. It's also attached to the bed. So the patient is there in a relatively fixed position. They can move their body but not their head. And we can see the digital output. I just want you to listen to this. Okay, I'm not sure if you could make that out, but as the patient twisted his arm, you could hear a response there to that cell. So that's how we know that we're in the part of the brain target, for instance, globus pallidus, that is important in the control of movement and not in another part of the globus pallidus that's close by that we might not want to be in, or in another brain area. So I show you that to, again, just to point out why we have patients awake and how we make sure we're in the right spot. The other way we can do that is with patients asleep in the MRI. And this is a quick kind of cartoon video that shows how this works. So this is all done with the computer system and specialized software that's used to help us after we plan the target and the safe trajectory through the brain to then instruct the surgeon where to make the opening in the skull. We can follow the path of the electrode in and then we can finally verify that it's in the right location. So why would we do one procedure over the other? There's some patients I see that say, oh, it's been done awake for 15 years. Why would I do something new? Yes, I'd like to do that. I'd like to participate in awake brain surgery. I'd like to participate in research, for instance, in the operating room. And there are other patients that say, wait a second, I can be completely asleep for this. Are you crazy? Yes, please, I would like to have this done in the MRI. We have some preliminary data as well as their data from other groups that basically show that doing this operation either awake or asleep probably has the same efficacy. And I really believe that to be true. So when patients ask me which one's best, it really depends on the patient. So some patients, especially some with dystonia, would be very uncomfortable to be awake in the operating room. Now, we can do the procedure asleep in the operating room with the frame the way that's normally done. But I think it reduces the quality of our microelectrode recording, so in that case I would rather do it in the MRI. Okay, just a couple pictures that show you that we convert an MRI scanner into an operating room for this procedure. Okay, I'm getting close to the end of the slides. So who's a candidate for deep brain stimulation surgery? I think I have it a little bit easier in this regard than the neurologist because I tend to see patients that are further along in treatment become a little more clear. So I have a kind of simplified way of looking at this. But the first thing that's important is to have a definitive diagnosis. So someone who is still in the stage of figuring out, okay, do I have hemifacial spasm? Do I have blepharospasm? Is there something else going on? Is this related to something else that's happened to me in my life? That person is not a good candidate. So one thing that you need to have is a diagnosis of primary dystonia. Someone should be refractory to medical management. Okay, this is a brain surgery. The risk for this surgery for doing both sides at the same time is about a 1% overall risk of a stroke that would cause a permanent neurologic deficit. That could be a problem talking, a problem moving part of your body. 5% chance of infection. Okay, so those risks are pretty low, but they exist. So you need to have tried appropriate medical therapy. Realistic expectations. So I think I addressed this previously in terms of what the expected outcomes are in terms of relief of symptoms. So we go over this again and again, and an important thing also is the time that it takes for stimulation to take effect. So it's a therapy that you have to stick with, but for properly selected patients, it really should work in terms of improving quality of life. So that's the goal. This is an elective surgery. And the key questions in thinking about this for patients and family members is what's the goal in terms of improved quality of life? What is it that the disease has done that takes away the ability of the patient to do something that they really like to do, haven't been able to do, have had to stop working, for instance, stop driving? How well can they deal with that? What treatments have been tried previously? Weigh the risk and benefits in terms of what it takes to go through the surgery, and then see where things kind of wash out at the end. Let me show you this patient just because it's an interesting patient. This is someone that we operated on literally yesterday, and he left the hospital this morning. Whoop! I do have that. Let's push this button.
I had this dystonia for about 4 or 5 years, I think. Been gradually getting worse, and so I'm looking forward to DBS surgery on the 15th of August. When I get nervous, such as when I'm visiting my doctor, the neck problems are harder to control than otherwise. And I have some facial movements as well that happen, and so I'm taking artane and xenazine to do that. I'm looking forward to getting rid of the xenazine, though. That's the medication that it helps, but I don't want to take it. I don't like the effects of it. Because even though I did very well apparently on my psychological examination, things like short-term memory recall or something, I just, when I get tight, and then the head starts to move and things like that, it makes it hard to concentrate on what we're doing. So.
Okay, so I think that illustrates a couple important points. One is patient expectations. So, we put down the video camera and say, we need to be clear that you might be able to reduce the amount of medication you're on, but you might not be able to go off it completely. That's a big expectation. Patients really want to get off medication, which is an appropriate goal, medication reduction. Everyone does have to undergo standard neuropsychological evaluation. We do that for everybody that undergoes deep brain stimulation because we like to track whether or not there are effects in mood or cognition. There usually aren't, but that's possible. And this is someone who had success with botulinum toxin in the neck, but basically did not want to undergo repeated toxin injections in the head or face, and is also someone who elected to undergo the interventional MRI procedure because he just wanted nothing to do with being awake in the operating room. Okay, so in summary, we know that DBS is an effective therapy for primary generalized dystonia. We think it's a good therapy for craniocervical dystonia. The small case series would support that, although there still has not been a very large trial that demonstrates this definitively because it's hard to recruit that many patients. And the best target is not well understood. There are currently two choices, and that's a discussion that needs to be had with the patient in terms of differences in potential outcome. Lastly, for those of you that live in Western Pennsylvania and may want to come back to the beautiful University Club in September for another symposium, we are having a general symposium on brain stimulation. It will include some talks on dystonia from our movement disorder neurologists. So if you're interested in that, you can Google University of Pittsburgh and deep brain stimulation. You can find all that information. Okay, thanks very much for your attention.